Okay, again, good morning, good afternoon, everyone, for today's session, IHCC Educational Webinar Series. So Michelle will be moderating this session. The floor is yours, Michelle, please.
Thank you so much, Latifa. And just for me also, very welcome to everybody on this IHCC educational webinar, and a special thanks to our speaker today, who's taking his time out to educate us and tell us more about this exciting work that he's doing. So just to give you a little bit of a background, so Dr. Jelte Kelchtermans is a pediatric pulmonology fellow at the Children's Hospital of Philadelphia, also referred to as CHOP, where he integrates genomic and environmental and clinical data to investigate air pollution sensitivity in pediatric asthma. So he graduated from the University KULeuven in Belgium with a BSc in medicine, and then earned his MD in 2015. So he started his research career as a medical student working with Dr. Allergaert at KULeuven, where he studied the pharmacokinetics of paracetamol and ketorolac during delivery and in postpartum periods in humans. Subsequently, he worked with Dr. Wu at the University of Miami using a rat model to study bronchopulmonary dysplasia. And he has done amazing work. And as his training progressed, working in clinical pediatrics, he made the ongoing morbidity of pediatric asthma in the urban population abundantly clear. He joined CHOP for his pediatric pulmonology fellowship, where he combined his personal background in basic and clinical research with exceptional genetic data available from the Center for Applied Genomics and the expertise at the Center for Excellence in Environmental Toxicology. So in his current work, he focuses on integrating data from the Environmental Protection Agency, the CHOP EMR, and the Center for Applied Genomics Biobank to describe variability in ambient temperature, ambient air pollution sensitivity in pediatric patients with asthma. So I'm sure he's going to be telling us a lot more about his recent work, and we're very much looking forward to hearing how you leverage this public data to really understand why children are sensitive to air pollution if they have asthma. So thank you so much for joining us, and I'm going to hand over to you.
Wonderful. Well, thank you so much for that kind introduction. As has been mentioned, my name is Jelte Kelchtermans. I'm one of the pediatric pulmonary fellows over at CHOP. We don't have a group that's too big today, so at any point, if any questions come up, if anything doesn't quite make sense, or if you just wonder about something and would like me to go into it a little bit deeper, please don't hesitate to let me know. It is a little harder for me to see the chat when presenting like this, so feel free to either unmute yourself or potentially send a message to Michelle so she can let me know. I have no relevant financial relationships to disclose. I will be discussing some unpublished data. When I do that, there will be a little banner at the bottom of the slide just to let you know that that data has not yet gone through peer review. My objectives for today is to describe the classical approach to exposure research, to understand some of the limitations of that approach, and then the potential benefit of expanding on that exposure research with a sensitivity dimension. And then really, of course, given the focus of today's session, understand the role that large biobanks can play in that sensitivity research. In order to do that, we're going to go through these 7 topics. Don't worry, they are not all very long. I just want to make sure that you know where we're at. So let's start with why I am interested in asthma and air pollution. As has been mentioned, I am originally from Belgium, which is this tiny little country here, these videos. So tiny little country just north of France, south of the Netherlands, and I went to the KULeuven there. And as you can see, Belgium is one of those countries where people very much like the bike. So whenever students go to class, they typically do so by bike. After I got my medical degree, I moved to Miami for my pediatric residency, and I got to live in this tower right here, which has a wonderful view of all the fireworks and things in Miami. And while I was there, I got to work with Dr. Shu Wu, focusing on trying to mitigate the effects of oxygen exposure in rat models of bronchopulmonary dysplasia. Now, since I am Belgian and since I'm very used to going to work on a bicycle, and since the hospital where I was doing my residency was only a little 13-minute bike ride away, I of course biked to work, which in the United States and in the areas I was biking is not always the safest to do. So my wife absolutely thought I was going to get murdered. And the reason for that is here you see those really fancy skyscrapers in the background. And this is the area I was biking through, and that's Overtown. Overtown used to be a fairly wealthy middle-class neighborhood until the 70s when they put this large freeway right through the middle of it. So my biking route was right over here, going to work right here at Jackson Memorial Hospital. And on my morning bike ride, which was about 2 miles or 3.2 kilometers, the neighborhood quite changed, and children in the areas that live there have vastly different health outcomes. And just to give you one example, when I started my morning bike ride, I was in an area with a child mortality rate of around 2.5 per 1,000 live births. By the time I got to work 15 minutes later, I was in an area with triple that. So really enormous health disparities and health differences in a very, very small geographical area. So by the time I got to the Children's Hospital of Philadelphia, I was very interested in drivers of heterogeneity in diseases in general and pulmonary diseases specifically. So I went to go look for people that are much smarter than myself. And I found those in 2 places at CHOP. First one is at the Center for Excellence in Environmental Toxicology, and that's under the University of Pennsylvania. And then the Children's Hospital itself, of course, hosts the Center for Applied Genomics. I also need a little bit of extra training, so I was able to do a Master of Translational Research during my fellowship. And when you're asking what drives heterogeneity in pulmonary diseases, one of the answers you're going to get, and one of the things that really comes up is ambient air pollution. Specifically in asthma, we know that it's a significant driver of both asthma severity and asthma incidence. With globally there being a yearly 1.85 million new cases of childhood asthma due to air pollution exposure. Let me highlight how most of the current exposure research is done, and I'm going to use a little example that we did for that. So this is the typical kind of study design. You have your population and you split them in a group that's highly exposed to whatever pollutant you're interested in, and you compare them to people that are non-exposed, or if you can have non-exposed, maybe just a group that's a little bit less exposed. So knowing that there is a significant link between air pollution and asthma, we asked the question, is there a link between air pollution and bronchopulmonary dysplasia as well? For non-pulmonologists in the room, bronchopulmonary dysplasia is really children that are born very prematurely and have some lung development issues. We know that there are socioeconomic factors and race-associated differences in BPD outcomes, with people from lower socioeconomic groups having worse outcomes. And we know that ambient air pollution can cause oxidative stress, which is also a central pathway in BPD pathology. So since air pollution exposure in the United States is closely linked with socioeconomic factors and race, we asked ourselves, as part of the difference that we're seeing based on socioeconomic factors, really an exposure difference. So we took our bronchopulmonary dysplasia population and we split them in exposed and non-exposed. This was a collaboration between ourselves and Johns Hopkins, and we looked at different bronchopulmonary dysplasia morbidity outcomes, things like sick visits, emergency department visits, hospital admissions, systemic steroids. And what we're really kind of seeing mostly across the board is a nice dose-dependent relationship, where if you lived in a low pollution zone, you have much lower rates of these morbidity outcomes. And as you move to areas with worse air pollution, which we defined as a bad air quality index, you have a higher incidence of all of these morbidity outcomes. Now, of course, you're all saying, well, wait a minute, Jelte, aren't you just capturing the effects of socioeconomics and racial factors? And that's a very good question. In this kind of research, you cannot randomize your patients. So you have to manually control for any possible confounder. You cannot rely on randomization to do that for you. So we did a logistic regression model correcting for any and all confounders that we could capture. And we continue to have some significant associations there, specifically between moderate and high air pollution exposure and the need for systemic steroids or the need to go to the emergency department. So we believe that air pollution exposure is a factor in bronchopulmonary dysplasia heterogeneity, but that information doesn't really get you very far. It's important when you're talking to your policymakers and when you're trying to set community-wide health priorities, but it's much harder to translate this into basic science or even into advice to give to your patients. And the same we see with asthma, despite the fact that we now have 20 to 30 years of strong data showing that air pollution really has some detrimental effect on patients with asthma. To date, the only recommendation we give to our asthma patients is try to avoid air pollution exposure, which, as you can imagine, is not the most effective approach and may actually be contributing to some of the health inequities that we're seeing in pediatric asthma in the United States today. What we actually need is therapy that can protect patients from the effects of air pollution exposure while we get the air quality better, which is a longer process. So there have been some studies trialing this, but the results have generally been fairly disappointing. And even if we found good results, those have been extremely difficult to reproduce. And that's really a consequence of our classical study design. This study design, comparing exposed to non-exposed, really asks the question, what is the effect of the exposure? And that's a really good question to ask if you can change that exposure. But if you cannot change that exposure, or if it's very difficult and it takes a long time to change that exposure, it becomes really difficult to use the data from these kind of studies. What we actually need to know is how we can protect patients that are exposed from the effects of that exposure. Now, why is that difficult to do? And I'm going to talk about some of the challenges in sensitivity research. One of them is this, and these are two examples from the asthma literature. I find these graphs absolutely beautiful, but I did borrow them from Kaufman et al. It's a wonderful article. It's definitely worth a read. This first graph right over here looks at the effect of a genetic variant and endotoxins. And what you can see here is that the effect of an exposure is the exact opposite based on the genotype of your patients. And then over here, this is tobacco smoke exposure, again, the genetic variants, and you're really only seeing an effect of that genetic variant if your patients are exposed to tobacco smoke. So it doesn't take a lot to imagine that if I'm doing a large cohort study and I am not accounting for these type of effects, I either may have no effect at all where true effects exist, or it may be very difficult to replicate my findings in a different cohort that may have a different genetic makeup. So we think that our patients are exposed to a spectrum of air pollution. We also think that sensitivity is a little bit of a spectrum, probably depending on genetic variants. So if we have an association between our exposure and our outcome, that may be driven by the entire population. But what we think is more likely that there is a subgroup of patients that is sensitive to the degree of exposure they experience. And when I'm talking about sensitivity, an immediate question that may come to mind is, how do you measure sensitivity? What previous work has done typically has looked at asthma diagnosis, sort of kind of asked the question of the patients that are exposed to air pollution, who develops asthma and who doesn't develop asthma. And that's a good study design. The only shortfall of that is that you cannot track that over time. That's a 1 or 0 outcome. You can't say, oh, we see this happening more frequently or less frequently in this patient when we start this or that medication. So it becomes very difficult to account for modulating effects of other variables. And as we will see, dimensionality quickly becomes a problem in this kind of research. Now, luckily, we live in a very exciting time, and we have a lot of data available to us that was not available to us before. So we do see some opportunities to overcome these challenges. And the first is, this is within the United States, but there are similar databases around the world. And at the end of my presentation, I'll actually give you some examples. But we have the Environmental Protection Agency, and that's a federal agency that maintains the air quality system. The air quality system is really a database that pulls together data from monitoring stations across the United States and provides you with overview data files. It also has an application programming interface that allows researchers to interact directly with their database to get very specific information covering specific time periods and specific geographical areas. I also have the good fortune of working at the Children's Hospital of Philadelphia and specifically with the Center for Applied Genomics. We currently have around 100,000 pediatric patients enrolled in our biorepository. Those 100,000 patients have consented both for genomic analysis and, very importantly, the mining of their electronic medical records, or EMRs. So we have a lot of clinical information on these patients, and we have a lot of genomic information on these patients. So we know that exposure is a spectrum, but we have a lot of exposure data. And we know that sensitivity is a spectrum, but we have a lot of clinical and genomic data. So with all of that data, we wondered if we would be able to identify a subgroup of patients that is sensitive to the degree of air pollution that they are exposed to. And for that, we used a little bit of a new type of approach. So first, in our large database of 100,000 patients, we looked for patients with asthma. For that, we use a phenotype that we've previously validated. So patients above the age of 4, we needed at least 2 asthma-related ICD-10 codes at least 2 different and independent clinical encounters. Patients needed to have at least 1 asthma-related prescription, think like an inhaled steroid or something like that. And then we excluded patients with significant other pulmonary diseases, such as cystic fibrosis and things like that. I noticed I forgot to put the reference for our phenotype on the slide, but I'm happy to share, of course, if anyone has any questions. And in doing that, we found around 8,000 pediatric patients with asthma in our database, where we captured a lot of clinical information as well. We had some more patients, but not all patients had all of their clinical care provided at CHOP. These 8,000 patients experienced around 34,000 asthma exacerbations. And when you look at the makeup of our cohort, this is very typical for a inner city asthma cohort in the United States. The slight male predominance, around 5–6% of patients with severe asthma, and then a predominance of patients with self-identified Black or African American race. And what we did for our 8,000 patients is we looked at their air pollution exposure. So we wrote a program that interacts with the Environmental Protection Agency database that looks at the patient's home zip code, gets the central coordinates of that zip code, and then it calculates the coordinates for a square centered on those zip codes. It then goes to the EPA database and it asks, in that square, please give me all of the data from monitoring stations that were active 2 weeks before to 2 weeks after any asthma exacerbation that our patients had. And then we used an inverse distance weighting formula to approximate the air pollution exposure at the zip code centroids for our patients' home zip codes. And we were able to do this for carbon monoxide, particulate matter 10, SO2, and O2. For particulate matter 2.5 and ozone, we used air quality index data that's more widely available. The downside of that data is that it's not as granular. That data is provided at a county level, so we can't model that data. Because we're using an inverse distance weighting formula, and because we're using zip code centroids, you do have to account for the fact that zip codes aren't as big everywhere, and you don't have as many monitoring stations everywhere. So we limited that modeling approach to patients living within Philadelphia. That still gave us around 7,000 patients that we could include. Now, in the classical approach, we would look at patients within our group that are exposed and compare them to patients that are not exposed. But because we're interested in sensitivity, we did this instead. So we still split our population in people that are exposed to air pollution and people that are not exposed. But then we subdivided our exposed cohort in groups that are exposed and seeing consequences of air pollution, and patients that are exposed but not seeing consequences of air pollution. And we'll go into how we define all of this in just a minute. So that really allows us to ask the question, why are some patients affected and how are those patients different from patients that are not affected? An additional benefit of this that I did not highlight before is that both exposed and affected and exposed and non-affected patients live in the same areas. So you're immediately accounting for a lot of confounders that you're not accounting for before. So let's start with splitting up our entire population in exposed and non-exposed patients. So what we did is we used data from the last 15 years to look at all of the zip codes in our cohorts and look at how frequently we're seeing days with bad air quality. So on the y-axis here, you just have what percentage of days had bad air quality, which we defined as an air quality index above 50. This blue line right here is 75th percentile for all zip codes in our cohorts. And what you see on the y-axis is the number of patients. So what you see is that the vast majority of our patients live in areas that experience frequent air pollution, which is not surprising since air pollution is associated with asthma incidence. So what we use is we use this cutoff of 75th percentile, and patients above that group we considered to be exposed to frequent incidences of poor air quality. Just as an aside, this table just shows you the difference between those two groups, exposed and non-exposed or less exposed. So people above that 75th percentile and below that 75th percentile. What I want to just highlight here is two things. One, these groups have very, very different racial and socioeconomic makeup. So when you look at self-identified race, the vast majority are Black or African-American patients live in areas with poor air quality, which is consistent with prior studies in the United States. When you look at household income, people living in areas with high air pollution exposure have about half the household income people that live in areas with better air quality. So again, enormous differences in both socioeconomic and racial factors, which comes with a lot of societal differences that you would have to account for because you cannot randomize these two groups. What we did in the next stage is we tried to split our exposed group into patients that were seeing the consequences of that exposure and patients that were not seeing the consequences. And what we did for that is we looked at what is air pollution doing just before an asthma exacerbation. So in our group of patients that live in a high air pollution zone, these are all of the asthma exacerbations. In red are the days just before an asthma exacerbation, and in blue are dates 2 weeks before, 2 weeks after asthma exacerbation. So we used 2 weeks before and 2 weeks after as our control dates. We got a baseline exposure, and then we compared that baseline with the days leading up to it. What I'm trying to show you in this figure, that is when you look population-wide, you do not have any association between air pollution exposure and asthma exacerbation, which is not surprising since we think that both exposure, but also sensitivity are a spectrum. So what we try to do is we try to define a subgroup of patients that does have an association between air pollution and asthma exacerbations. So out of all of these exacerbations, we selected those that are associated with a spike in air pollution, at least 2 standard deviations above the mean from that baseline period. And if you do that, you get something like this. So this is the data for ozone. And what you can see is when we choose specifically those asthma exacerbations that are associated with a spike in air pollution, then obviously there is a difference from baseline. And there is a subset of asthma exacerbations where you do see an association between a spike in air pollution and that asthma exacerbation. So based on that, we made that subdivision. If you as a patient experience your asthma exacerbation immediately after a spike in air pollution, then we called you affected. If you have a patient did not have that temporal association with spikes in air pollution, despite the fact that you live in an area with high air pollution exposure, so despite the fact that you would have had plenty of opportunities to have asthma exacerbations induced by air pollution exposure, then we called you non-affected. And that's really how we define our sensitive and our non-sensitive groups. When you compare those two groups, the first thing that stands out is that now your groups are a lot more homogeneous. These are people that are living in the same neighborhoods, that are going to the same schools, that have very similar socioeconomic and racial factors. So again, self-identified race, almost the same. When you look at mean household income, still a statistically significant difference, but no longer an enormous difference. So it's around $3,000 as opposed to a $35,000 difference that we saw earlier. What we also see, and what's very interesting to us, is that you're seeing enormous differences in asthma severity. were patients that had that temporal association of having their asthma exacerbations immediately following a spike in air pollution, being almost 4 times as likely to have severe asthma, much less likely to have mild asthma. Also, the number of exacerbations is significantly higher. The other interesting thing that we noted is that we have much higher rates of viral infections. So patients with that sensitivity to air pollution have about 1.5 incidence of RSV and rhinovirus, and these are PCR confirmed infections. This is just a different way of presenting the same data. So this is for carbon monoxide. We looked at all of these different pollutants. The trend was the same across the board. Much higher rates of severe asthma, much higher rates of moderate asthma, higher rates of viral infection, higher rates of allergic sensitization, and higher rates of family history of atopic disease. So we are able to define a group of patients that we think has a different sensitivity to air pollution and that is exposed to air pollution. We are able to show that these patients have a different clinical course, that this is clinically meaningful. But the question that we then had is, are these patients also genetically different from patients that are non-sensitive? So what we did is, first and for all, before we looked at our own data, we did literature review. This is a busy slide, I apologize for that, but this is a slide summarizing what genes the variants identified to date track back to. So all of the variants that have been associated with air pollution sensitivity and pediatric asthma are associated with the genes presented on these slides, or this slide. And what you may notice is that there's 2 very well-known pathways, especially within pulmonary pathophysiology, that are implicated. One is the nuclear factor kappa beta pathway, which plays a major role in steroid sensitivity in pediatric asthma, and the other is the pulmonary antioxidant pathway. So with that knowledge, we looked at our group and we compared our exposed and affected patients with our exposed and non-affected patients. We used genotyping data for this, and we found 9 SNPs that had genome-wide significance, 3 of which are intergenic. 1 was an EQTL in lung tissue, and 2 were EQTLs in blood. When we looked at the genes implicated by these SNPs, there's 6 genes. I'm not going to bore you with going into every gene in detail, but I am happy to geek out about this if anyone's interested. All 6 of these genes have been strongly implicated in asthma severity before. Interestingly, 4 of these genes are linked to air pollution sensitivity in animal models already. So that kind of supports the validity of our model and of our approach. We also wanted to take a look at a little bit of the wider architecture and some of the pathways that were implicated with our results. So we used a p-value threshold of 1 × 10⁻⁵ and looked at, okay, if we look at just all of the things that are lighting up, are there any specific pathways that stand out, any pathways that we may want to investigate a little bit further for gene-gene interaction studies or things like that? When we do that, we found around 450 genes in patients of African-American ancestry, about 500 genes that were implicated by the variants in patients of European ancestry, and very, very strongly that nuclear factor kappa beta 1 human lung inflammation pathway was implicated, which, just to remind you, is the same pathway that's been implicated in prior studies. So overall, we're able to find a subset of pediatric patients with asthma exacerbations just following spikes in air pollution exposure. These patients have more severe asthma despite correction for any clinical and socioeconomic confounder that we can think of. We see that there's genetic variants that are associated with the sensitivity. So we think that there's a genetic basis for the sensitivity to short-term changes in air pollution. And we think that there's specific pathways that are implicated by genetic evidence. Now, of course, this raises more questions than it answers. Are there gene-gene interactions? Are there rare variants? We only use genotyping data so far. So what we're currently doing is we're starting off some metastasis studies looking for gene-gene interactions along the nuclear factor kappa beta pathway. We're also completing whole exome sequencing of our asthma patients, which is very exciting work. And then we're looking at some of the clinical differences between air pollution sensitive and non-sensitive patients. We highlighted before that there's viral infections, allergy sensitization, family history of atopy that is different between these 2 groups. We currently don't know if that's an association or actually a causation. But this is where what we did has a unique advantage. So we were able to link air pollution exposure with asthma exacerbations. So that allows us a model to look at air pollution exposure, clinical factors, and genetic variants over time. Are there specific time periods in a child's life where they're having more asthma exacerbations than patients that are non-sensitive? And is that occurring right after viral infections, or is it before viral infections? Are there specific medications that appear to modulate the sensitivity? So very exciting and fun to work with. But as you can imagine, this type of work very quickly starts to struggle with dimensionality, where if you have 10 clinical differences, you need enormous patient numbers to actually be powered to see differences. We also found some EQTLs that were significantly associated with air pollution sensitivity. So that kind of raises the question, how does genetic variation, air pollution exposure affect gene regulation and expression in pediatric asthma? And could we potentially find a fingerprint both of exposure, but also sensitivity and response to that exposure? Hopefully in the future, that will actually allow us to identify and protect sensitive populations and then improve health outcomes, decrease some of the inequity that we're seeing in pediatric asthma today. So because we really want to shift the focus from exposed to non-exposed to sensitive and non-sensitive, I was very, very happy that I had the opportunity to present here today. Because like I alluded to, this work struggles with high dimensionality and the need to subdivide our cohorts by pollution exposure. So you really need large numbers of patients to do this properly. This is where international collaboration is of critical importance. Now, the time to do these kind of studies is really now, and this is just from a couple of minutes of looking around the internet. These are government websites of governments and governmental organizations across the world on every continent that we have member cohorts that track air pollution exposure over time, and integrating this kind of publicly available data into our data sets may actually allow us to start identifying some of these genetic variants that may not have a population-wide effect, but only have an effect in the presence of specific exposures. I would be remiss if I didn't thank the Educational Webinar Series Committee for their hard work putting all of this together. My personal mentors, Dr. Hakon Hakonerson from the Center of Applied Genomics, Dr. McGrath Morrow from the Center of Excellence in Environmental Toxicology, my home division for supporting me through all of this, and then of course my thesis committee members and collaborators, my funders. I am very happy to take any and all questions, so please feel free to unmute yourself. I'm going to close the slideshow for now, just because it's a little bit easier to see people actually interact that way.
Great, Jelte, thank you so much. That was a beautiful presentation, so carefully thought out to take us with you on this journey and trying to understand, what's happening. And I love the fact that you leverage, the existing data. I'm very happy to see that there's some South African data as well, seeing that that's where I'm based. And, we often say in Africa, we don't have a lot of data. So I think not many countries do, but at least there is some. There was one question in the chat, which I think I'm going to just put to you, because it's really, going right back to, your first premise about dichotomizing the groups into high exposure, low exposure. And we know it's a continuum, and you said that. So how did you decide, and are you happy with how you decided to do this?
Yeah, it's one of those things that's we try to find a reasonable cutoff. So looking at our population distribution, there appear to be kind of several bumps based on where our population was located. So it allowed us to define some different groups. Could you make an argument for splitting that into 3 or 4 or 5 groups? You could, at the expense of some of the statistical power, of course. So it's a little bit of a weighing. There is probably a difference between having 1 in 10 days being air pollution exposure days versus having 50% or 60% of your days being air pollution days. Is there as much of a difference between 25 and 40%? There really is no good data currently to say that. What we try to do is try and have a reasonable cutoff in extremes for air pollution exposure, while also controlling for a lot of socioeconomic confounders. So with the split that we chose, we were really able to capture patients from fairly similar socioeconomic and racial backgrounds, which helps us account for some of the variables that we cannot otherwise account for.
Thanks. Yeah, and I think, also talking about cumulative burden, obviously not so easy to measure, but that lifetime exposure,
And even prenatal exposure is very interesting.
Oh, fascinating. Wow.
There's some data that maternal exposure during pregnancy influences asthma incidence and all of those things, but it's interesting.
Is that through an epigenetic mechanism or still not known?
It's not known, but that would be my my guess, yes.
Yeah. Carl, please go ahead.
That was a great talk. Really appreciate it. So I'm a exposure scientist at the National Institute of Environmental Health Sciences, and I've worked a bit on geospatial exposure modeling of air pollution. One thing we know is that certain air pollutants have very high spatial and temporal variability. And you mentioned the highway going through there, and of course that's a major source of multiple types of air pollutants. But it can drop off pretty significantly there, where you might have someone who lives within a half a kilometer of it with 2-3 times the exposure levels there. And there was the comment from my colleague also here at NIHS about the dichotomizing. It would be, I think, really great if you could keep it on a continuous scale, right? Because I mean, the AQI is continuous. There's also exposure models that actually do really well, and so this is something I've seen a lot, is that folks in my field that are kind of air pollution and exposure scientists, we really need to reach out and partner with the people in the clinical setting and contribute that expertise, and it would really just elevate studies all around it. And so I guess it's more of a comment than a question. I mean, it was given the sample size, you said you had about after
so we had around 8,000 patients.
8,000. So and that was after a cutoff based on exposure levels, right?
So after the cutoff, we have right around 6,500 patients.
Okay. So I mean, I don't know
So I actually really love that you bring this up, and I've had a lot of conversations about this with Dr. Blanca Heims at the Center for Environmental Toxicology here as well. The way I see this kind of research, and this is a little bit of the difficulty with this kind of research, because you have uncertainty on the exposure side and uncertainty on the sensitivity side, is you try to make one side more stable, and then you look at the other side and you cycle back through. So the way that we're hoping to use this kind of data is start off with a kind of good enough kind of, we think this is a reasonable kind of cutoff on the exposure side, look at our genetic data, look at the patients that are genetically predisposed to be sensitive, and then look back at their exposure in more detail. So to basically cycle back through using that rough estimate at the first time, but then looking at a more detailed exposure thing, saying, okay, we think these patients have genetic variants that put them at increased risk. When are we actually seeing asthma exacerbations and worse disease in these patients? Where this work will have to go eventually, and this is something where I think we all kind of know the exposure work has to go through, is away from the modeling and towards more direct measurements. It's very exciting that NASA launched the Tempo satellite just a couple of months ago now, where we actually can have 1 mile by 1 mile. I think it is PM 2.5 measurements across the United States on an hourly basis. So really much more granular, much more detailed data. So very exciting that that's coming out as well. But it is absolutely a little bit of a iterative process, so to speak. What we were concerned about is that if we look in too much granularity on our exposure side, we would spend our power there and we would no longer have the power to do genetic studies. What we did see, however, is both with the air quality index data, which we used for PM2.5 and for ozone, compared to the model data that we used for the other 4 criterion pollutants, we see remarkable consistency in our results. The other thing that we used is, instead of using a numerical cutoff, we used a relative cutoff. So we called a exacerbation associated with air pollution sensitivity if it was at least 2 standard deviations above the mean for the control period for that specific model location. So while we kind of assumed that exactly our measuring stations are a little bit closer to highways, they may be influenced by everything under sun, and the sun itself, to be fair, at least it'll give us an idea of local conditions around that time period. So if local conditions were very conducive to an exceptionally high value for a specific pollutant at the location that we're modeling for, it is more likely that our patients are also experiencing something that is somewhat out of the norm for them, as opposed to an exact number, because we know that there's some reliability in our assessment, if that makes sense.
So maybe, sorry, did you want to follow up, Carl?
Well, I was just gonna comment and say I appreciate that. That was an excellent response and certainly enlightening in how, when you're trying to investigate the genetic variability there, that you need, you gotta make some sacrifices on the exposure side. But
not for too long. I want to go back to the exposure side. It's super fascinating to go into that in more detail as well.
Yeah, so always making trade-offs, right? Yeah, because one thing I did want to ask you, Jelte, is the IHCC has cohorts all over the world, and you talk about the NASA data. Is it the same level of granularity in different countries, or do they really focus their data collection on the US?
So it's actually quite interesting. There's a lot of heterogeneity in data collection across the world. So NASA just launched the Tempo satellite, but the European Space Agency also has a Copernicus project going, which looks at air quality. I think it's currently only within EU member states, but I'm not entirely sure. It may actually be looking a little bit broader as well. China has amazing air quality monitoring network where they actually supplement data from some of their monitoring stations with, in some cities, they have taxis equipment, air quality measurements. So they got a little bit of a more dynamic view as well. So it's really highly region dependent, but a lot of data is available in the public space. So it's kind of interesting to start thinking about how we can integrate some of these large publicly available data sets in our bio banks.
Absolutely, because I'm just reminded we do a very small study trying to look at air quality, and one of our major challenges is having robust enough air monitors for our settings in rural Africa. Yep. And of course, one of the major issues across many parts of the continent is dust, just from dust storms, rather than pollution by cars and other things.
Yeah, a really interesting thing to me is that a lot of the asthma literature that kind of connects asthma outcomes with air pollution doesn't even pretend to try to model exposure or anything like that. They use one central monitoring station at the hospital, like outside the front yard or something like that. And they say, oh, look, this connects with asthma all across the city. So it's in a way a little bit reassuring that even with fairly inexact exposure data, you find reproducible, consistent, strong associations. I think we would be a lot better off if we have better exposure data, but it's somewhat interesting that you don't actually need the really, really good exposure data to get some kind of association, at least.
Yeah, that's absolutely fascinating. Just want to encourage everybody to put up their hands if you've got a question. I've got a few more, but I'd love to hear from all of you, as I'm sure Jelte would too. So Jelte, while they're thinking, I was interested in your genetic association study and the fact that you got more significant associations in your European ancestry group than in your African ancestry group, which is sort of counterintuitive knowing how much variation there is. Is this a power thing about a smaller sample size in your African ancestry group, or I can't remember now.
We actually got higher. So we, I think out of our 9 SNPs that met genome-wide significance, 6 of those were in, no, 7 of those were in patients of African-American ancestry, and that's genetically determined African-American ancestry. 2 were in European ancestry. And also when looking at those pathways, the results were very similar between both groups, where for both ancestries, that was that nuclear factor kappa beta 1 pathway that was strongly implicated. I think we had p-value of somewhere below 1 × 10⁻20 for both ancestries.
Oh, okay. No, that's amazing. I think I was thinking about another slide where you had like 500 and 400 or something, but that was a different cutoff perhaps, or...
So that cutoff, we had more genes implicated by variants in our European ancestry, but I think that's because our power there was a little lower, so we just had a little bit more heterogeneity in the results.
Yeah, because I think we don't have good African data also for EQTLs. And we need to build that up, because all the data that we're using is primarily based on European origin, and we don't know how different that might be. So that'll be really interesting too. I don't see any hands up. Maybe to ask you just, a little bit about the future and where this is going. Do you I know, really understanding G by E is so important, because you want to identify the most vulnerable given a certain environmental situation. Do you think that the research that you do could identify new drug targets, for the more vulnerable, if we understand the G by E, to then treat it?
That's absolutely our hope. We know that drug discovery or drugs that have been implicated by genetic evidence are about twice as likely to make it to market than drugs that are not targeting areas that have been implicated by genetic evidence. So we know that taking this into account when coming up with potential targets is extremely important. Now, very interestingly, that nuclear factor kappa beta pathway already has a lot of targeted therapies toward it, specifically because it's a pathway that's so important in treatment-resistant severe asthma. So what we actually wonder about is if we would stratify some of those studies by exposure, would we get even better results? Could we see a higher impact, or can we define groups that would benefit from these therapies more than just our overall population? Because I think that's probably a major takeaway from this work today is your studies are only as good as the factors that you're taking into account. And if there's a big blind spot in your study, if you're not accounting for certain sensitivity or exposure, you may miss something relatively big.
And in the global literature, is there transferability from pediatric to adult cohorts?
So it's interesting. We're not sure yet. What I would love to do is see if these, I didn't put the slide in there, but it's actually interesting that some of the variants that we found are associated with long-term, lifelong pulmonary function test trajectories. So where we see decreases in FEV1, decreases in forced vital capacity in patients that have some of the variants that are associated with air pollution sensitivity in our cohort. So we strongly believe that there is kind of a commonality or a common pathway at work there. The American Thoracic Society also recently came out with a statement saying that air pollution is likely a contributor to any and all kind of pulmonary pathology. So it's hard to see how it would be completely different, so to speak.
Yeah, because I was just thinking about, you're leveraging like the UK Biobank or the All of Us. And I know the UK Biobank, they started recruiting at age 50, so that's not going to help you with your pediatric patients. What is the story with All of Us in terms of age? Is it also 18 and above?
So they have some pediatric patients as well. What I'm currently working on and struggling a little bit more with is trying to get some exposure assessments on these patients. If you have some kind of localizing data, you can kind of start looking at air quality where they live. But when we look at the genetic variants that we identified as having a significant effect, if we look population-wide, that effect is completely diluted out. You really need to look at patients that are at least exposed to higher amounts of air pollution, which is also why we took such an extreme cohort of people that were absolutely the absolute worst air quality, which is a little bit the downside of this kind of research, because you do have to kind of make choices either on the exposure or on the genetic side.
Because I was fascinated by your route on your bicycle and how things changed just in that very short space. Sure, it's amazing. Yeah. And then I did notice that more boys than girls were affected. Is this, I don't know anything about.
So slight male predominance is typically what we see in pediatric asthma that flips after puberty, which is kind of an interesting, something that we've noted in asthma before, but that was kind of consistent with asthma as a whole. That wasn't that different in our sensitive cohort and the rest of our cohorts this week.
Okay, great. So, the good thing is that we've recorded this, so hopefully other people from the IHCC will be listening in. And I know that you made a plea for potential collaboration. So if people do have cohorts that, could potentially be used to bolster this research, I think that would be absolutely wonderful. So I'm going to hand back to Latifa now. She's got some announcements to make, and just to thank you again, Jelte, for this amazing talk. I think it was so interesting and instructive, and good luck with the research going forward.
Thank you so much, and thanks so much for having me.
Thank you, Michelle, for moderating this session. And thank you, Dr. Jelte, for this great presentation. Yeah, thank you, the participants, for your attendance. Please mark your calendar for the next webinar series that will be taking place on May the 25th at 9 a.m. Eastern Time, 2 p.m. UTC by Dr. Sarah Bromister. I put this information on the chat box, and the title of the talk is going to be Multi-Cohort Mental Health Research and Analyst Training with Dementia Platform UK. Looking forward to seeing you during our next webinar, and thank you again for your participation, and have a great day.